Good afternoon, everyone. I'd like to thank AIOC for giving me this opportunity. I have no financial disclosures. Now, I'm sure each one of us, post-cataract surgery, you look at the eyes, you look at the reaction, and you think, at least during the early stage, is this a sterile one? Is this an infective? If it is an infective, is it a bacterial, viral, or a fungal? And some of us think, okay, let's wait and watch and see how things change, and you end up with a picture like this. So this is when you rush the patient to the OR, do a very invasive AC tap, vitreous tap, send all this to the lab. And this is a very unpleasant experience for the patient. And definitely this patient won't be coming back to us. Because a missed or a delayed diagnosis can lead to blindness or a loss of ocular texture. So early detection is the key. So the research question is, can we actually do a non-invasive, quick, simpler, more affordable test? To do this, we looked at tear biomarkers to predict which infection is going in the eye or which type of infection is going in endophthalmitis. So this was the inclusion and exclusion criteria. We excluded any kind of lid abnormality, and we did a detailed ocular and systemic examination. Sample was collected of the tears, and aqueous and vitreous, microbiological analysis and metabolic profiling also was done. Basically, we did gram stain, culture, PCR, and mass spec. This is how the sample preparation and data analysis was done, but I won't go into the details because of shortage of time. So if you look at the results, you can see clearly very distinctly altered tear metabolites in bacterial endophthalmitis as compared to control. And also what you see is, you can see downregulation of M-carnitine, which reflects altered fatty acid metabolism and cellular stress. And also you can see upregulation of methylenolinate, which means protective anti-inflammatory pathway may be getting exhausted. Now, very similarly, even you see altered tear metabolites in viral endophthalmitis, especially upregulation of lipid-related metabolites and downregulation of protective amino acid, that is taurine. So here you can see, even in fungus, we see uniquely altered tear metabolites, which mainly reflects oxidative stress and nutrient consumption by the fungi. So what we know, what was known was, diagnosis of endophthalmitis is based on clinical examination, and it is supported by microbiological investigation of a very invasive AC tap and a vitreous tap. What this study adds is, to the best of our knowledge, this is the first study which shows tear biomarkers which can predict the type of infection that is happening in the eye or endophthalmitis. The altered metabolites correlate wonderfully with, in the tears, correlate with aqueous and vitreous, and may serve as an early diagnostic modality, obviating the need for an invasive test. But how do we use all this information in the future? So we are currently trying to develop a diagnostic kit. So with this, the next time we post-surgery, we see reaction in the eye, and we want to know what is happening just with a Schirmer strip that each one of us, every single practitioner, can everyone has it just by collecting the tears with a Schirmer strip, put it in this diagnostic kit. Within 30 minutes, you have the report in the hand, and you can be very specific on the type of infection you're treating. So that way, we can prevent or delay the multi-drug resistant infections, which is supposed to be the most deaths that can happen in 2050. Thank you so much for your time.
Thank you, Naren. Is the device available in the market now?
Yes, sir. So right now, the diagnostic kit is not available,
Okay.
sir. So what we have identified is the tear biomarkers.
How long you have done the research? How many patients in the year?
So the sample size was 98, sir.
Okay.
98.
Good. Thank you.
Thank you, sir.
So, madam, you
Very
can start.
thought-provoking talk. Can you tell me if you have mixed infections? Is there something? I mean,
Yes, we
often
have
we
we
see.
have excluded any of those, ma'am.
No.
We have been very specific. We did have some couple of cases where they were mixed, but we have excluded it because we wanted to see specifically if it is purely bacterial, how the host response is. So that's when the metabolites. So in the past, people have tried to isolate, try to do PCR or culture. None of it has worked. So this is the only test which is non-invasive we can do. And what the beauty is, usually AC tap and vitreous tap, we have to think twice. Oh, can we do now? Can we this? But the tears, we can repeat morning, afternoon, evening, and keep monitoring how the disease progresses and be very specific on how the treatment also changes.
Thank you, Devin. Thank you.
I have a question.
You are talking about multi-drug resistance and everything.
Yes, sir. Yes, sir.
How do you get to the antibiotic sensitivity first in your tear film or tests?
Yes, sir. So here we are not doing antibiotic sensitivity, sir. So, yeah.
This was about diagnosis.
Yes, yes. So this is purely on seeing, be very specific on what is going on in the eye, because normally what happens, sir, we go into one panic. We see endophthalmitis and we like start putting the patient on all the high-end this one and all the drugs and everything. And that's when we do a blanket treatment, which I think that is something that we should avoid.
One question, specificity and sensitivity.
So it's about 98%, sir. Both specificity and sensitivity, we have about 98%. Sir.
That's good. Thank you.
Dr. Vivekananda here.
Thank you, sir. Thank you.
Okay. Next speaker after Dr. Usha is the Dr. Prasanna here.
Yes, sir. Yeah.
Dr. Soham Basas. You can come here. Next amendment. Please start.
Respected judges, I'm here to present the 25-year retinoblastoma care journey in a tertiary eye care center. Retinoblastoma is the most common childhood eye cancer, yet 88.5% present with advanced disease. Historically, enucleation was a treatment of choice due to limited advanced treatment resources in developing countries. Vision preservation seemed impossible. In a cohort of 1,055 patients followed up over 25 years, we found out 662 unilateral cases and 395 bilateral cases, all from southern part of India, presenting with leukocoria 81.7%, strabismus, red eye and reduced vision. 80.5% of the patients presented within 3 years of age, despite 88.5% having advanced disease groups D and E at presentation. Multimodal treatment protocols achieved excellent outcomes in this cohort. 60.4% underwent systemic chemoreduction, 35.2% underwent focal therapies, and 5% underwent intravitreal chemotherapy. Enucleation was reserved for life salvage cases, which is a dramatic shift from the historical paradigm. Overall survival was 80.8%, good vision was preserved in 76.9%, and globe salvage was possible in 78.3%. Why does this matter? These outcomes rival the developed world standards, demonstrating that systematic multimodal protocols, not resources, are the key to success. Most importantly, children preserve sight and normal quality of life instead of facing blindness or disfigurement causing a societal burden. We underwent 589 probands and families were tested for genetic analysis, of which 37.5% had de novo germline mutation, 20.4 had somatic mutations, 35.8 had no mutations, and 6.3 had inherited disease, which implied that genetic counseling was mandatory, family screening is important, risk assessment guides monitoring intervals and prevention strategies, reproductive planning was important for affected families. 44% of the patients in this cohort harbored germline mutations, emphasizing the critical importance of incorporating genetic testing, counseling, and family surveillance into comprehensive retinoblastoma care protocols. This information significantly impacts long-term management and family planning decisions. Cost-effective, time-bound, relevant sequential molecular screening of retinoblastoma helps predict the risk of retinoblastoma for siblings, offspring in the RB-affected family, risk of other cancers in later part of their life. This was the mutation spectrum, which was in hundreds, but 20 were unique for our population. 76.9% of them retained useful vision, normal schooling was enabled, employment opportunities were provided, independent living was made possible. Low vision aid training of visually challenged patients were provided for better quality of life. Social rehabilitation through ocular processes was provided for enucleated sockets. So the 3 pillars for change for global impact would be implement multimodal protocols, systematic approach, train the providers, and to detect early, create awareness, educate parents, screen for leukocoria, and support through genetic testing, family counseling, long-term follow-up. Evidence from 25 years and 1,055 patients is vision preservation is achievable worldwide with the right strategy, not just the right resources. Thank you very much.
Can I? May I?
Let
Yeah,
me
Dr. Usha.
congratulate
Lovely
you,
paper.
Dr.
Sorry. Lovely paper, lots of work. I know you said it through the paper. Just been happy if you had just clearly stated what was known and what you added. You added a lot. And you did put it as a footnote why it was important. Just for the benefit, what have you added? Which is...
Yeah, so the one thing which I have learned over the 25-year journey is there's a lot of noise around intra-arterial chemotherapy, but it is not feasible, economically viable in our developing country. And what we see is people have been moving up the survival rates, but not significantly to match the Western survival rates. So today we have come to 80%, when we were earlier at 20 to 30%. So how was it possible? Not through intra-arterial, but through simple intravenous systemic chemotherapy. And what even Shields, who is promoting and propagating intra-arterial, has admitted that it's not possible in developing world to have intra-arterial, which costs about 1.5 lakh per sitting, versus a chemotherapy which is just going to cost us 5,000 per sitting.
Thank you.
Thank you. Thank you, madam.
That was, every geography has its importance.
Astounding
एक
work.
मिनट डॉक्टर शतांशु
Astounding work,
minute,
Dr.
please.
Usha. Just a small thing. Have you analyzed socioeconomic status of your cohort of patients?
So one thing that we've done, and it is almost like a CSR activity of our hospital. All the patients, most of the patients, I would say about 10% only could afford a chemotherapy. The rest of it was all provided free of cost from the hospital setting.
No, I was asking in interest because there was a paper I went through a long time back that lower socioeconomic, there's more
Yes,
prevalence
madam. That's what I
in
said.
that.
10% only
Okay.
could afford. So the rest of the 90% belong to the lower socioeconomic strata.
one more question, ma'am. Other than what the options are available now for various stages of retinoblastoma, what is there in pipeline to in the coming time to take care of
Yes, sir.
these
We
cases?
didn't just stop with genetic analysis. We are looking at chemoresistance. We are looking at targeted therapy now. We are looking at what are the points where we could target, and that's also in the pipeline. So all these would go a long way. And being done in India is going to be very economical and viable, sir. Thank you very much.
Okay. We'll move on to the next speaker, and we will restrict to one question per candidate for the paucity of time.
Next speaker after Basak is Professor Rupesh Agarwal. He there? Rupesh Agarwal? You are here?
Rupesh, please get ready on the second.
Other podium. Chalo, you start, Basak.
Yes, sir. Good afternoon, everyone. I am presenting the 5-year outcomes of DMEC using 2 different donor preparation techniques, no financial interest. So DMEC is slowly replacing DSEC as the surgery of choice for treating endothelial dysfunction. And most of the modifications are being done in the surgery techniques to minimize endothelial cell loss for better graft survival. So from anatomy, we note that the peripheral cornea has got a higher cell density compared to central cornea. So what we have modified is we are preparing a peripheral donor tissue so that for a same diameter, we can give more endothelial cells. And we have already published short-term results, and this is basically a long-term follow-up of the same cohort. So this was a retrospective comparative interventional study. We took 500 eyes of 442 patients who underwent either peripheral or centrally trephinated DMEC. All patients who completed 5 years were included, and the primary outcome measure was basically endothelial cell density at various time points. Secondary outcome measure was visual outcome and secondary graft failure. So this is briefly what the outcome, what it looks like. In peripheral DMEC on your left, we make a very eccentric trephination versus what is conventionally described as a central. So coming to the outcomes, finally we had 428 eyes of 383 patients. The demography, indications and procedure was similar. Only difference was prior glaucoma was more in the DMEC CD group. The donor characteristics, preservation time and graft preparation time again were very similar in both the groups. Now in your primary outcome measure, we can see that for all time points, the DMEC PD group is significantly having much better cell density compared to what is conventionally described in the central group, which is again very evident from a graph. Now if we do a subgroup analysis, both for Fuchs dystrophy and for pseudophakic bullous keratopathy, the DMEC PD group is again far surpassing that of the DMEC CD groups. In terms of visual outcome, both the groups achieved good vision and maintained in 5 years. There was no difference at all time points. Now coming to secondary graft failure, the DMEC-CD group had more secondary graft failures. However, it was not statistically significant. If you look at subgroups, in the PBK group and I syndrome group, the DMEC-PD tend to perform much better. DMEC done for failed grafts were equally failing, and DMEC done for Fuchs were doing equally well. This is a representative patient where one eye was done central, one eye was done peripheral. Now coming to discussion, this is one of the very large series with a very long follow-up. And if we compare to, this is a very busy slide, I'll just highlight the points here. So what we are noticing is, in spite of having a varied heterogeneous etiology, our endothelial cell count is doing as good as the Western outcomes. And if we look at only the Fuchs, then it is far performing much better than what is reported from the Western cohorts. However, the vision outcome for us is slightly less. Definitely this reflects the more various and more difficult corneal etiologies that is being done in our part of the country. And unlike that of DSEC or PK, where we cannot do this anatomical eccentricity, in DMEC it is possible. So we are leveraging basically what is the physiologically what is important for us. And this is our recommendation. So from to 2018, we are almost for all our cases doing the peripherally trephinated donors. It is difficult for younger donors or diabetic donors where the DM stroma addition is more. The strength of the study is the large sample size, a good follow-up over 5 years, and heterogeneous etiology. Limitation would be retrospective design, a non-randomized design, and some missed follow-ups during the COVID-19 period. So definitely a multicentric study, and doing it at the various parts of the world would be very interesting to look at. Thank you very much.
Yeah, thank you.
Thank you.
So one significant advantage that you can tell compared to the DMEC Central or for DMEC PD, what is the one significant advantage that
so
you
for
can
say for a 8mm graft, if we do a peripheral versus a central, the number of cells that we are transplanting is more. And also now there is growing evidence that there might be some pluripotent activity or some regenerative activity in the peripheral endothelial cells. So although we are not reaching statistical significance, the number of secondary graft failures is definitely half, 44% less in the DMEC peripheral group. So
thank you.
Thank you, sir.
Thank you. You can start.
Thank you, panel, for giving me the opportunity to present my work on novel biomarkers to identify from the tears and the serum to identify the differences between the infectious versus non-infectious uveitis. And this work was funded by the National Medical Research Council grant from Ministry of Health, Singapore. So to start with, we just wanted to set up the problem statement upfront first. So the problem statement is that the infective uveitis in the form of prototype case of TB uveitis, difficult to diagnose based on the test available right now. And it also, the pathophysiology is not very well understood. There are few studies which are done in the past related to proteomics. So we, in our study, we thought we'll study the proteomic profile from the ocular surface, that is from the tears, and also parallel samples from the serum to differentiate between the IGRA positive, which is TB positive, and IGRA negative, which is TB negative patient, and also to assess the correlation with immunoglobulin. So just I put up one slide here, the status of affair, where the TB diagnosis is based on the clinical phenotype, based on endemicity, based on certain specific features of the phenotype, and based on certain corroborative tests. We do other tests also to support that. But how about putting more specific tests, particularly from something which is more specific and which is more accessible? So that was the aim behind starting the study. So how did we went ahead about setting up the study? It was a prospective study where the parallel samples of serum as well as tears from the patient with IGRA positive and IGRA negative were collected, and also a follow-up study was done at 6 months as well. The sample size was smaller, but still we went ahead with the robust analysis for the proteomics using the tandem mass tech quantitative mass spectral analysis. And this is the spread of the patient, which was quite evenly spread between the two groups. But I just wanted to highlight the results of this study. And though this looks like a busy slide, but just to keep the thing simple, this study shows the overall outcome, that what happens in the serum proteomics and the tear proteomics. So there were 30 unique biomarkers for IGRA negative and 39 unique marker for IGRA positive from serum. And likewise, there were a unique marker for IGRA negative and IGRA positive. The name has been blurred because we have filed some patent under it. Therefore, I just kept the name as a proteomics, as the biomarker. These results also, when we compare for the tier IGRA positive and IGRA negative, these are just the 4 of the specific biomarker which were very highly significantly differentiated between the 2 groups. Same thing for serum as well, you can see, and also at the 6 months how the differences were noted. Just to complete the results and the chart, we also wanted to set up a mechanistic pathway wherein all these proteomics were also subjected to a certain specific mechanistic pathway to understand what is the mechanism which lie behind and how these proteins are either upregulated or downregulated. So this is just an overview graph of showing that this dysregulated proteins were put through this pathway to understand why and are they really meaning, or this is just an observational outcome which was coming out of this study. So this is one of these things. Now, of course, we want to compare with the literature. So there are 3 studies which I like to highlight. This particular study from Netherlands, also shown in the studies in the vitreous proteomics, where the vitreous proteomics were showing as a differentiator between the lymphoma and the uveitis, and therefore we are able to identify that uveitis can be used, the proteomics can be used in patients with uveitis. This study from our own PGI group from Dr. Rima Bansal, Professor Amod Gupta and their team also shown the proteomic profile of vitreous in patients with tubercular uveitis, but we do know that getting vitreous sample can be tricky, therefore we are focusing on getting the ocular surface sample. Now, just a futuristic study, the study done by the group from Netherlands and Indonesia, where I was also involved, about looking at a serum B lymphocyte activation and how it can help us differentiating feature between the immune response in sarcoidosis as compared to the tuberculosis. So I just given you a very brief overview of 3 top study. Now, what I want to do in the future, we want to apply some of the AI machine learning technique. You will say, why do you really need to do that? Because sometimes there are so much of cloud, so much of information which is available. So 2 particular techniques under this, which is recursive feature selection and sequential feature selection, were applied just to get very specific outcome from this entire complex data set which we get it, so that we can get very specific biomarker, and therefore we can design the lab on chip which can be very helpful in diagnosis. So to conclude, our results does show that there is a differentiating between the tier and serum proteomic marker between the 2 particular group, IGRA positive and IGRA negative, and there is a correlation with immunoglobulin, and future studies, the validation studies is required before we can really jump into and set up lab on chip. Thank you very much for your patient listening.
Thank you.
Thank you, thank you. So, our next speaker is at number 2, because he was not here. Dr. Vivekanandan, we are number 2. After Vivekanandan, we have speaker Dr. Apurva Agarwal. Prasanna has to come. So, Prasanna, you can come here. Okay, you start.
Okay. Good afternoon, everyone. So today I'll be talking about outcomes of a novel 4-flange scleral fixated using regular PMMA lens and a specialized 7-O-proline suture. So the purpose is to evaluate the clinical outcomes, the vision, the IOL centration, and the duration of the surgical procedure. It's a prospective study done over 2 years in 74 patients. Patients with aphakia or having inadequate capsular support were chosen. Patients with corneal retinal pathologies and history of scleritis was excluded. But why this study? So the conventional flange techniques involve either a 26 gauge or a 30 gauge needle, which make a large sclerotomy, and there is tissue loss. And when you have a large sclerotomy, you need a large flange to plug the sclerotomy. If you have a large flange, you're going to have difficulty in burying. There's going to be an elevation on the conjunctiva. There can be conjunctival erosion as well. And moreover, it is a time-consuming process because you have to dock the suture into the 26 gauge needle, do the sclerotomy, interiorize the suture, exteriorize the suture. It will take 15 to 20 minutes on one side. It will take 30 to 40 minutes when you're doing it on both sides. So we wanted to solve all these problems, and we came up with a solution. So we designed a spatulated needle which is 150 microns attached to a 7-O-proline suture which is 16 millimeters in length. So using this, we do the procedure. So here a sclerocorneal tunnel is constructed, anterior vitrectomy done. So the conjunctiva tenons is held 1.5 millimeter away from the limbus. The first sclerotomy is done by moving it radially, and 6 clock hours away from it, the second sclerotomy is done using the same needle. Now you can see the needle is docked into an irrigating cannula, and the needle is brought out of the sclerocorneal tunnel. So now we have 2 sutures coming out of the sclerocorneal tunnel. So the sutures are passed through the dialing hole of a regular PMMA lens, be it single piece or 3 piece, and a flange is created using the portable cautery. A flange, make sure it is larger than the dialing hole itself. The IOL is pushed inside the eye. The IOL is centered, and then the suture is trimmed only to 1 millimeter, not more than 1 millimeter, and a flange is created. So the first flange is done on the transconjunctival side. The suture on the opposite end is pulled to bury the first flange. The second flange is created by holding the suture very close to the sclera, indenting it, trim to about 1 millimeter. Here also just 1 millimeter, and a flange is created. The surgery is over. So apart from the PMMA lens, through the clear corneal incision, we do the foldable lens by piercing at the optic-haptic junction with the same needle. We have done torics as well. Apart from SFIOL, single sclerotomy, CTS, and iridodialysis repair is also done. To perform this procedure, you need a PMMA lens with dialing hole, any single piece or 3-piece, the suture, and the cautery. So all cases underwent anti-vitrectomy, no PI was required. So coming to the results, 78% of our cases of aphakia that we took for surgery was mainly because of complications due to the prior surgery. The others were because of subluxation and dislocation. The mean preoperative BCVA was 0.35 logMAR, which improved to 0.26 logMAR at POD 30, statistically significant vision. The POD 30 mean spherical equivalent improved to 0.01 diopters, which is also statistically significant. The centration, we had 2 cases of IOL decentration at 1 month post-op in a dilated pupil. On undilated pupil, they were fine, so we did not have to do any resurgery. There was no change in the intraocular pressure. Coming to the main thing, 60% of our cases, the surgical time was less than 30 minutes. The complications include 8 cases of vitreous hemorrhage on POD1. This is mainly because of the bleed due to the through the sclerocorneal tunnel. So we made it mandatory to cauterize the sclera before doing the tunnel, and then this complication stopped. At the end of 1 month, we had 3 cases with CME. So discussion coming, this is a novel technique using any PMMA lens to do. It is a cost-effective procedure. There is no tissue loss unlike the 26 and 30 gauge needle, because it is a slit-like sclerotomy. It's less amount of suture required for flanging, only 1 millimeter, short learning curve, and lesser duration of surgery. Just a comparison between the needle that we designed. It's a spatulated needle which makes an incision roughly about 250 to 120 microns, so it is like a thin slit, compared to a diameter of 400 or 340 microns. When you have a diameter of 340 to 400 microns, you need a flange larger than 400 microns. So you have to flange 3 to 5 millimeters of suture, which is going to cause an elevation on the conjunctiva and tenons. But whereas with this needle, you need a flange larger than 150 microns. So just 1 millimeter of suture required to be flanged. So this is our comparison of our technique with the other existing techniques. So it has shown safety, efficacy outcomes. Our long-term follow-up is needed. We have follow-up up to 5 years, but we need more. These are my references. Thank you.
Thank you. Have you compared the stability with the other techniques like sutured or the haptic is inserted into the have you compared it?
Yes, sir. Yes, sir.
Stability.
Sir, what we have found out is there is no torsional tilt because we are not involving the haptic. We are anchoring at the optic being a rigid structure, there is no torsion. The only thing we find is if the bisection, if the 2 sclerotomies are not exactly 6 clock hours away, there is tilt in the IOL. So it is very important that we use a toric marker or something before we make the sclerotomy. And the distance between the limbus and the sclerotomy has to be equal on both sides. If it is a little bit, if it is 1.5 and 1.7, then you might see a tilt.
Thank you. Thank you. Thank you. So
I'll just ask one question. Your logic that you're anchoring at the optic and not at the haptic is wrong. The tilt will be more when you are anchoring at the optic.
Sir,
just a minute.
Yes.
On the axis, you are on the axis. The tilt on the axis will be more. I did not see results of the astigmatism. You did not put up a result on the astigmatism. Thank you.
If you want to redressal, just 20 seconds.
Yes, sir. Sir, when we are going to pull the haptics out and fixate it, I agree with you, sir. So there is going to be a torsion because one IOL, if it is not exactly buried, if both sides you are burying at 2 millimeters, there is not going to be a problem. If it is a little over, you are going to have torsion of the intraocular lens. Whereas when we are anchoring at the optic.
Thank you, thank you. So next speaker Prasanna, he is a number 4. He was also not present here. Number 4, speaking on visual fields.
Thank you, sir. Transforming visual field reports into engagement 3D tools from XY to XYZ space. Theory has many limitations. We did come up with 3D printed circulophilus, cavernous sinus, and the eyeball models previously, and they served as great pedagogical tools which we reported in literature. The similar problem statement of animating perimetry, making intuitive and interactive learning for real world scenarios to grasp concepts, especially for residents. The 3-dimensional cone, when examined from top, doesn't give much sense on a 2-dimensional plane, which we are doing for visual fields as well. And that was a problem statement which we took And this is how it started the journey, by making a lot of animation grids on the exact points, be it for a 24-2 or for a 30-2 on the numerical scale, and the real definition of visual fields. The reality is differential light sensitivity, where the macula can actually pick up the points which are very sensitive, that makes it the real hill, whereas as we go to the periphery, the alumni can even be more brighter. So that's what forms the visual field as a three-dimensional hill. And the numerical grid resonates with the similar finding. So the XY axis was extrapolated to the Z axis, and here you can see one of the first printed 3D models of the visual field, and a different sensitivity of threshold. Each threshold was taken into consideration with technology of 3D printing to get a much better pedagogical cognitive concept orientation, and the superior arcuate scotoma, the normal hill, and certain other two-dimensional visual data were evaluated, especially the quadrantopia and the isopter contraction. So these are concepts which people don't understand, especially the residents, as to how the hill actually reduces in height. But making the three-dimensional functional test, as visual field is known as a three-dimensional functional test, never evaluated in 3D, with technology of Maya we made sure it was possible, along to Cura to curate it, with polylactic acid as the material. The three-dimensional construction was done for these 4 models and many more. The hill of vision, arcuate scotoma, quadrantopia, as well as isopter contraction. And the study set into place with the setting of neophyte residents, a cross-sectional comparative study with a questionnaire-based approach. The timer changed, sir, actually, when I was speaking. It was 2 minutes, and
I think it jumped.
It jumped, actually. It was just
Yeah,
2
it's
minutes.
fine.
Yeah,
You got to do-
I'll finish it in 3 more minutes. It's a questionnaire-based scale on the Likert scale. 2 groups, one for theory, another one with 3-dimensional visual field model training, with the 10-session feedback questionnaire was aroused after a focus group discussion, with interpretation, understanding component being 38% of the questionnaire, recognition of the visual field effect, usefulness of the teaching method, and innovative representation, with the 2 different groups compared with pair t-test and p-value evaluation was taken into consideration. Quantitative analytic parameters like confidence levels in interpretation, diagnostic accuracy, understanding the pattern, qualitative considerations like common difficulties, what were the positives, and scope for improvement. The 4 points were the Likert scale 0 to 4, with 56 participants making it 224 points, which was evaluated with the standard deviation for the following questions. Did the session help you to understand the visual concepts better for the 2 classes, where the ability to interpret visual field reports improve? And on the right hand side, you can always see that the reports were much better, with the overall learning experience being evaluated. The clear visualization of the visual field effects were evaluated. Correlating the visual field effect with progression or severity was also done. Confidence in interpreting the visual fields in sessions were seen. Reducing errors in interpreting the reports. Teaching module as a trainee, how do you conceptually receive it, and understanding it on a 3-dimensional plane, as it is a 3-dimensional functional test. And last, would you refer this, or would you want this to be in your ophthalmological training curriculum, for some of the parameters? The Likert scale with percentage mapping for the 2 groups on 224 points, with 165 being on group 1 and 184 cumulative being on the group 2, with a p-value of statistically significance with 0.001 coming on the group 2. The component 1 of the discussion is quantity. On quantitative module, high positive reviews because of the conventional, it's rather more innovative rather than the conventional training of visual field model in 3-dimensional cognitive plane. Component 2 is the quality, the improved conceptual understanding, learning engagement, especially to accelerate learning, and there was good strengthened learning on a qualitative level. The discussion is, these are modules which not only helped the neophyte residents as an educational tool, but also made sure to get the concepts to the patients as well. In future, maybe with more studies, accessible and comprehensible, where the students' cognitive satisfaction will improve, more intuitive understanding depth of the contour, distribution and depth, because visual fields, there are sloping scotomas and then there are scotomas which just dip like that, which are concepts very difficult to grasp. Education, diagnosis, and maybe future for patient understanding for better compliance as well. These are my references. Thank you once again for giving me this opportunity to present in the finale. Thank
Dr.
you.
Prasanna, you have improved the accuracy from 73 to 82%. Any future option, plan, scope of involving AI to make further improvement and reach the target of 10% accuracy?
Sir, 100% may not be possible, but we'll definitely
Theoretically,
working towards it with the AR as well as AI technology, sir. Yes, we are working on it, but it may take some time to crack it, sir. Yeah.
Very, very novel concept. Can you project it visually, 3D visually?
Yes, ma'am. This was actually made digitally. This was made digitally, and then we have now taken a printout of it for a cognitive tactile learning, and the ranges of 10 degree, 20 degree, 30 degree. Not only that, but how a scotoma slopes. Because an NTG patient, the central scotoma is steeper, deeper, and closer to the fixation. That is a concept they don't understand, because the 32, 31 directly falls to 10 or 0 sometimes. And even isopter contraction, many people did not have a clear idea what it was. And when it was shown three-dimensionally that it was just a hill coming down because of the sensitivity of points that is actually coming down, enhance their learning to diagnose the condition better.
Thank you, Prasanna. Thank you.
Thank you, sir.
So now proceed to next, Dr. Shroff.
At the
And
outset,
next, Dr. Yogita is here. Yogita. And after Yogita, Usha Tejaswi. So you can speak from here.
Please be ready on the second podium. Yes.
at the outset, I'd like to say that I have no financial disclosures related to this presentation. Now, we all know that dry eye is becoming more and more of an issue, and especially this kind of patient where the tear metrics and the symptoms don't correlate, where the patient's disproportionately high pain and discomfort can't be explained by the tear film metrics, are the subgroup that bother us a lot. Now, when we look at the ocular surface, if the blink happens before a breakup happens on the surface, generally the patient is okay. However, if the breakup happens before the blink, then you can see these various different issues that can come on the ocular surface. There's enough evidence talking about the need for objective markers and how to modify blink symptoms to improve the ocular surface. The knowledge gap that we found was that few studies objectively measured blink kinematics, and no Indian-based study is there on AI-based blink reminder impact. There's limited research connecting blink patterns and intervention to improve this blink pattern and increasing productivity. We use the ID app to help us to do this. This is the app. It's basically a blink reminder app. It has either fixed or smart blink reminders, where it's actually looking at your blink pattern while you're using either your PC or your mobile phone, and that icon on the top left actually reminds the person to blink while they're using it. This is a video illustrating the same. This is the blink reminder. It can be an icon which can move to any part of the screen. There's also an auditory prompt which can be used, where if you don't want that pop-up to come on, the auditory reminder reminds the person to actually blink. There's also a 20-20-20 rule reminder inbuilt in the system, so every 20 minutes it tells the subject to take a break. So with this, we designed a prospective cross-sectional study of 150 software professionals. The interventional subgroup had 44 patients with more than 6 hours of screen time. We measured blink kinematics at the initial presentation. We also deployed the app with the auditory reminder without actually educating them as to what was going on, to make sure that we weren't altering their blink patterns. And then we looked at changes in the symptoms, tear metrics, and higher order aberrations at a later stage. No artificial tear substitutes were used for any of the subjects enrolled in the study. We subjected all of them to an OSDI questionnaire, a slit lamp evaluation, IDRA, Schirmer's test, and Oxford staining. We looked at the non-contact TBUT, lipid layer thickness, etc. We excluded anyone who had a history of ocular surgery, laser treatment, contact lens use, etc. We did the statistical analysis as per the MedCalc version 19 software. Post this, we actually educated the subjects as to the importance of blink, and then we did a post-intervention measurement at 3 months looking at tear metrics. Our results showed that the interblink interval actually reduced, and a significant improvement in partial blink percentage was seen in these subjects. The tear metrics also showed significant improvements in terms of the TBUT, the aberrations, the tear meniscus height, and the OSDI, or the symptomatology of these subjects. Another important thing that we noticed was if a person had mild and moderate symptoms, post the intervention, actually these converted to more of the normal group. So it's a bit of a busy slide, But you can see that the percentage of mild and moderate symptomatology has gone from 36 and 9% to 18 and 5, and that subgroup has reverted to normal OSDI scores. So what is the actual crux of the matter? How does this help us? Now, this is a study looking at productivity impact. It looks at the big 5 tech companies, and TCS did this study. Now, what we see is that 50% of these subjects suffer from dry eye, which is about 300,000 employees. The Osaka study talks about an average 5% decline in productivity. And if you look at the financial impact of this, it comes to about 6,000 crores in just one company. So if you apply this at a large scale, the impact at a population level is extremely high, especially considering all of us are on screen so much. So improving blinks is not cost, it is an investment to improve health. The limitation of our study was a small sample size and a shorter follow-up duration, and it's not available on the iPhone system. What was known was that computer vision syndrome is a growing public health issue. ID is a simple and inexpensive tool for ensuring blink hygiene, improving objective and subjective tier metrics. As the app is available on smartphones as well as desktops, it can preempt development of dry eye and have a huge financial impact. Thank you.
Okay, Dr. Urshad, one question, 2 parts. How often does the blink come on? And did any of the responders say that it was annoying?
So none of the responders said it was annoying. We used the smart blink reminder, which basically was analyzing.
How often?
So that's dependent on how you blink.
Minimum, maximum?
Minimum is 6 seconds, sir. So
every 6 seconds, I'm reminded to blink.
Yes, it can be. So it depends on how you're actually blinking, because if you're not blinking completely, then the levator muscle is not relaxing. Your MGD chance of developing becomes higher.
I understand that. What I'm saying is, if I'm working and every 6 seconds somebody reminds me that I have to blink, I'm wondering.
So it's an auditory reminder.
Whichever. Thank you.
Next speaker, Raghuraj here. Dr. Raghuraj, you can come here. Yes,
a very good afternoon. I'll be talking about prospective evaluation of AI-integrated fundus camera for glaucoma referral in a comprehensive eye clinic. Prevalence of glaucoma is expected to go up by 112 million by the year 2040, and 90% of the cases in developing countries still remain undiagnosed. Standard of glaucoma care includes or involves a wide range of clinical and confirmatory tests, as we all know. Now, what prompted us, or what was the background for this study? When we started using fundus photography in our vision centers, which are actually run by allied ophthalmic personnel, we saw that the detection of posterior segment diseases was increased by 2-folds. And when we utilized this AI-empowered fundus camera in the vision centers, we saw that it performed very well with respect to sensitivity and specificity in diagnosing glaucoma. With this background, we wanted to understand how this program is going to work in a busy, comprehensive eye care clinic. For this study, we have employed Remedios non-mydriatic fundus on phone 10 model, and this has been integrated with an offline Medios of artificial intelligence software. Our objectives were clear. We wanted to evaluate the performance of AI-assisted fundus camera in identifying referable glaucoma, and we wanted to see how well it is performing with respect to when it is compared with the comprehensive ophthalmologist. This was a prospective cross-sectional study. This was carried out in a high-volume comprehensive eye care, tertiary eye care hospital, and we had 1,242 patients in our study group. The sample size was calculated in order to attain 95% confidence interval. And methodology included, we included all the patients who were consenting to participate, aged 50 years or more, attending the comprehensive eye care clinic. We excluded all those who had sudden vision loss, active infection, or recent history of surgeries. Methodology actually happened in 2 stages. In the first stage, non-mydriatic fundus photo was captured. Only 2 attempts were made. If the image was not clear, we dilated the pupil and took 2 more attempts. The time taken for this process was captured. In the next stage, the patients were examined by the comprehensive ophthalmologist, who was completely blinded to the AI findings. In the subsequent next stage, all the patients who were flagged by the AI and all the patients who were referred by the comprehensive ophthalmologist and 58 controls who actually did not have any glaucoma, who acted as controls, were seen in the glaucoma clinic. Here, all of them underwent HFA and OCT, and they were seen by 2 independent glaucoma consultants, and they graded them as definite, probable, possible, or no glaucoma. If at all there is discrepancy in their findings, adjudication was done by a 3rd expert. Coming to the results, out of 1,242 patients, 87% of them we were able to capture gradable images. AI graded 5.8% as positive or referable glaucoma. Comprehensive ophthalmologist flagged 5.9% of them. A total of 159, which included 58 controls, were seen in the glaucoma clinic. And we found that in this cohort, we had 1.9% definitive glaucoma and 4.6% if we included possible glaucoma cases as well. Now, how did they perform? With respect to probable glaucoma, the sensitivity of the AI camera was 89% as compared to 84% of that of the comprehensive ophthalmologist. With respect to specificity and accuracy, they both did equally well. In detecting possible glaucoma, both the performances were actually very much comparable. Now, the other challenge, what about the cataract loop? In this cohort, 80% of the patients who had moderate to advanced cataract, we were still able to capture gradable images. And in this cohort, the patients, in fact, the AI module was borderline better performing as compared to the comprehensive ophthalmologist. How many required dilatation? About 20.9% who did not have cataract and 37.8% who had cataract required dilatation in order to capture a good gradable image. What about the extra time? We required only 1.05 plus or minus 0.3 minutes was additionally added to the normal clinic flow. Now, coming to discussion, AI managed to achieve high sensitivity and specificity just by relying on a good quality fundus image. With our own experience with this, when we carried this out in the Vision Center, we saw that the agreement between the AI program and the glaucoma specialist was the maximum, which was 80.3%. The same module has been utilized, and recently published paper showed that this has very good positive predictive value, and not just in detecting advanced or moderate glaucoma, this performed very well in detecting early glaucomas as well. Now, what was the strength of our study? We found that this was actually a first AI integrated fundus imaging system, which is looking at the real-time pragmatic application of this tool in the population. This was a cross-sectional study. In conclusion, I would like to say that the diagnostic performance was comparable to that of the comprehensive ophthalmologist, and going forward, this can definitely strengthen the detection of glaucoma and prevent glaucoma-related blindness. Thank you very much.
Ma'am, since it's a portable gadget,
Yes, sir.
can it be of some use in teleophthalmology
Yes,
to
sir.
take care of our community ophthalmology care?
Definitely, sir.
How do you propose it, or how do you, advocate it?
In fact, this study, what prompted us, like I mentioned, we have published this in AI in the community ophthalmology, where it is not done by the doctors, it is done by the allied ophthalmic personnel, and we were able to understand that AI performed very well in detecting this glaucoma. So they were flagged as this is the suspect, and this is the glaucoma patient, and this patient requires a reference. So the agreement between the AI and the glaucoma consultant was maximum, better than the teleophthalmologist also.
And you can breathe now.
Thank you, sir. Sorry.
Thank you. So next speaker, we have Rangachari.
Good afternoon, everyone. My talk, my paper is the role of maximum intensity projection in CT dacryocystography in dacryorrhea. I have no financial disclosures to make. Lacrimal fossa is formed by the lacrimal crest in the frontal process of the maxillary bone, and the posterior lacrimal crest formed by the lacrimal bone. And the lacrimal sac actually is a preseptal structure, and the nasolacrimal duct, when it continues, it is has intraosseous as well as membranous parts, and generally slopes posteriorly and opens just below the inferior turbinate. You can see the arrow marks show the anterior and posterior lacrimal crests. The maximum intensity projection, or MIP, is a 3D reconstruction technique that enhances the visibility of contrast in high density structures like bony tracts and blood vessels. The voxel with the highest intensity along a specific viewing image is projected into a 2D image. So basically a 3D image is projected into a 2D image for easy interpretation. So in our study, we did an observational case series of 10 patients with anomalies, different anomalies of nasolacrimal duct and the sac area. So the technique is basically we do a CT scan with 0.625 mm sections, and CT DCG is then done by administering a diluted contrast agent, which is mixed with the carboxymethylcellulose eye drops in a 1:1 ratio, and by the drop method. The drop method is basically we put one drop every 30 seconds for 5 minutes, and then scanning is repeated. Cannulation and syringing was done only in cases where this drop method failed to demonstrate in the lacrimal system. Then after that, we use the DICOM imaging software to use the MIP imaging tool. So this is how we do it in our PAC system, but this can also be done in using DICOM images, using a DICOM reading software, and which is freely available. And this basically we need to activate the MIP and reduce the contrast so that we can see the entire lacrimal system. You can see that it will, as we go forward, you can see that the entire lacrimal system is visible. So just to show a few case examples, this particular case where a midline tessier cleft 0 is post hypertelorism correction and facial translocation surgery about a year back. The child complains of watering discharge in the left eye in 6 months, and this looks to be like a secondary acquired nasolacrimal duct obstruction. This is the post surgery we did a CT scan, and since we are doing the CT scan, we also did try to do the post CT DCG. So in the left side, we can see that there's an absent definition of the bony components of the nasolacrimal duct, as well as accumulation of contrast in the sac itself without any obvious connection to the nasal cavity, suggesting at that level there is a obstruction. So this is another case where it is a post septoplasty and a bilateral inferior turbinate reduction. You can see that in the right side there is obstruction in the sac area, and it's not going through the NLD, but the left side it is going, and the patient had epiphora only in the right eye, and the sagittal sections show that it is not going beyond the sac. This is an acute dactylocystitis in a 7-year-old child. We had to do a CT scan in this patient, so we did a CT DCG as well. We can now see that the sac is filling up, and it is not going beyond into the nasolacrimal duct, but it is leaking into, some of the contrast is leaking into the abscess area, which is indicating that it is communicating with the lacrimal sac. You can see in the sagittal section that it is not going, the right side NLD is not communicating with the nasopharynx. So this is another patient where lacrimal pump failure, where a child who, when we did the drop method, it was only in the congenital cavity sac, but it was not going into the nasal cavity. But when we did a syringing, we could see that immediately the entire anatomy of the lacrimal system is revealed, and you can see that there is a beautiful image going all the way up to the nasopharynx, right from the canalicus to the sac to the NLD and up to the nasopharynx on both sides. So we did 10 cases, and in different cases we knew where is the level of obstruction as well as the possible cause of what happened. So this would give us a better way to evaluate these patients. The discussion basically, the 3 ways to interpret these intensity images, basically the minimum intensity projection, average images, and maximum intensity projection, which is what we are discussing in this paper. Minimum is basically the minimum intensity of in any slab, it averages and then there's an average which maximum minimum it averages out. Here it only the MIP maximum intensity projection, we only do the maximum along any plane it just takes the maximum intensity projection. So it will, wherever there is a maximum intensity, it will project into the into a 2D frame. So where is it used before this? Basically it is primary method of visualizing blood vessels in CT angiogram, as well as high density lung nodules in cancer screening programs, in acute ischemic stroke, and it helps assess collateral status, and gastric and esophageal varices with portal hypertension. How do we use it in NLD anomalies? Highlights the contrast with lacrimal duct system.
Thank you very much. Any question or comment?
No.
You're just enhancing what you see in ordinary DCG to make it clearer for the diagnosis. Thank you.
So after Raghuram, Dr. Purva here. Please come. After Purva, Dr. Rajeshwari Kapoor.
You be on the other side.
Purva, Rajeshwari, you come here. Sorry. Dr. Yogita, yes, she has not come. We should mark absent now, sir. It's about time over here.
Yes.
Yes.
Good afternoon, everyone. So my study is to the effect of preservative-free travoprost on proximal lacrimal drainage system using ASOCT. So topical antiglaucoma medications are reported to induce inflammatory and fibrotic changes both in the conjunctival surface and epithelial and subepithelial tissue of the lacrimal drainage system. So patient on these medications may develop watery eye either due to ocular surface disease or due to lacrimal drainage system obstruction. In our study, we have studied the proximal lacrimal drainage system, which begins from the punctum, continues as the vertical and horizontal canaliculus,
and then as the common canaliculus up to the internal common opening. The purpose was to study the effect of preservative-free travoprost eye drops on proximal lacrimal drainage system in newly diagnosed glaucoma patients using ASOCT. So we considered 3 parameters: external punctal diameter, internal punctal diameter, and vertical canalicular depth. So all newly diagnosed patients on monotherapy were included, and this was a prospective study conducted for 1.5 years. My sample size was 30 eyes. Comparison was done by ANOVA and Bonferroni post hoc t-test, and p-value less than 0.05 was considered as significant. So all patients with normal punctal diameters were included in the study, and patients requiring any adjuvant treatment or lid disorders were excluded. So imaging was done using Topcon DRI OCT Triton Plus OCT with anterior segment module. Images were captured before starting on topical travoprost therapy at 3 months, 6 months, 9 month and 12-month follow-up, and 3D anterior segment protocol was used. The lid was gently everted, exposing the punctum, and the horizontal line of the scan was placed parallel to the lid's mucocutaneous junction, and image was acquired. After acquiring the image, external punctal diameter was measured from the highest point on the nasal and temporal wall of the punctum. 100 micron below the external punctal diameter, the horizontal line measures the internal punctal diameter, and the vertical canalicular depth is from the perpendicular line from the external punctal diameter to the base of the punctum. So we saw that travoprost caused a substantial meaningful reduction in IOP over the study period. The external punctal diameter showed a few fluctuations, but there was no significant change over 12-month period. The internal punctal diameter remained relatively stable for 1 year, and vertical canalicular depth also remained stable over the observation period. So lacrimal drainage system obstruction has been evaluated previously by lacrimal probing, syringing, UBM. UBM is still used, but it can give low resolution images. So anterior segment OCT is an upcoming imaging modality to study the lacrimal punctum. This obstruction can be caused by the medications themselves, the preservatives used, or because of the duration of treatment. So we have used preservative-free eye drops in our study, thus eliminating the role of any preservative, which can be a confounding factor. And we saw that travoprost 0.004 eye drops do not cause any significant anatomical changes in the lacrimal punctum and canaliculus when used as a monotherapy for a duration of 12 months. Travoprost, known to cause ocular side effects like conjunctival hyperemia, watering, irritation, could be attributed to the inflammatory and fibrotic changes in the conjunctival surface. So travoprost is an effective anti-glaucoma medication causing significant reduction in IOP when used as a monotherapy. ASOCT can be used to quantify and monitor the proximal lacrimal drainage system changes and can also be used for patient education. And travoprost does not cause any significant anatomical change in the punctum and canaliculus as measured on ASOCT when used as a monotherapy for a period of 12 months. But the limitations were it was a small sample size, and since anti-glaucoma medications are used for a longer duration, we need long-term studies. But it was the first study, as per our knowledge, to evaluate the effect of travoprost on proximal lacrimal drainage system using ASOCT. And since preservative-free eye drops were used, the side effects caused by the preservatives could be eliminated. So we would like to recommend that punctal scan by ASOCT can be done in patients started on anti-glaucoma medications who complain of watering. This can help us differentiate lacrimal drainage system obstruction from ocular surface changes as the cause of watering and thus provide appropriate treatment to the patient. Thank you.
What was the range of the puncta you found before you started travoprost? Like before you're planning to start, was there a range or all the dimensions were equal?
There was a range which we had used a study. According to the study, the normal parameters were defined, and we had included all the patients who fit in those parameters. And then on follow-up, if the level is going, the value is going below the range, then it was considered as significant.
I'll ask a question. What was your control?
So this.
You have concluded that it's better, or it doesn't cause. What was your control? Against what?
We had not done a comparison study.
How can you say it's better?
It was compared over the time duration.
With what? Just a minute.
Like the same patient.
Second, no, that's done. You have used.
Think about it.
Think about it. Next time you do it.
Yes.
You were manually pulling the lower punctum.
Yes.
That's a confounding factor. One day you're in a good mood, you'll pull it gently. You're not in a good mood, you'll pull it stronger. The punctum is going to open.
Let us not comment all that. You should have had a
Control. What I'm saying.
control.
Thank you.
Thank you. So, next speaker should be ready, Dr. Vishal. Vishal here, you ready? Yeah, you start.
Good afternoon. I will be presenting a retrospective imaging-based study evaluating structure-function correlation in chiasmal lesions, specifically comparing macular ganglion cell complex and peripapillary retinal nerve fiber layer using OCT in relation to visual field effects. We begin with a brief overview of the anatomical basis. In the visual pathway, temporal retinal fibers remain ipsilateral, while nasal retinal fibers decussate at the optic chiasm. Compressive lesions of the chiasm preferentially affect these crossing nasal fibers, which carry temporal visual field information. This results in the classical bitemporal hemianopia. Therefore, chiasmal lesions provide a unique model to study spatial structure-function relationships. This brings us to how we assess structure and function clinically. Automated perimetry remains the clinical gold standard for functional assessment of visual field effects. OCT, on the other hand, provides objective structural quantification. Macular GCC measures ganglion cell bodies, while RNFL reflects their axonal projections. Yet, direct sector-wise comparison between GCC and RNFL in chiasmal lesions remains insufficiently explored. This gap formed the basis of our study. This was a retrospective imaging-based study conducted at a tertiary eye care center over a 3-year period. We analyzed data from 84 patients. Our objective was to assess sector-wise correlation using OCT and visual field testing. The mean age was 48 years. Approximately 64% patients presented with defective vision as the primary complaint. The mean symptom duration was 53 weeks. Pituitary lesions accounted for nearly 74% of the cases, meningiomas 24%, and craniopharyngiomas 2.38%. Now for the methodology, structural assessment was performed using Cirrus ST OCT, analyzing both peripapillary RNFL and macular GCC. Functional assessment was done using Humphrey Field Analyzer with CETA standard 30-2 protocol. Quadrant-wise mean pattern deviation values were anatomically mapped to corresponding retinal sectors. This slide summarizes the key sector-wise findings from our analysis. The heat map helps visualize how strongly visual field loss relates to structural thinning across different sectors and both eyes. The color brightness represents the strength of this relationship, while the numbers inside each cell show the effect size and the p-value. What we see is a clear pattern. The temporal visual field sectors demonstrate the strongest relationships, particularly with macular GCC. In comparison, RNFL generally shows lower effect sizes across sectors. The nasal sectors also demonstrate weaker relationships overall, which aligns with the expected anatomical pattern of fiber involvement. Overall, these findings suggest that macular GCC reflects the spatial pattern of visual field loss more closely than RNFL in chiasmal compression. What does this mean clinically? Our findings suggest that macular GCC demonstrates stronger structure-function coupling compared to RNFL in chiasmal compression. Temporal sectors show the highest correlations, reflecting the selective involvement of crossing nasal fibers. Importantly, OCT provides objective structural quantification, which may be particularly valuable when automated perimetry is unreliable, such as in patients with poor fixation, low reliability indices, cognitive limitations, or severe visual loss. Sector-wise analysis may also enable spatially guided monitoring. However, there are limitations. This was a retrospective cross-sectional study with a relatively small sample size. Longitudinal progression was not assessed. Sectoral mapping between visual field and RNFL was anatomically approximated. Additionally, OCT accessibility may be limited. Importantly, OCT complements but does not replace perimetry. Standard automated perimetry remains the clinical gold standard for functional evaluation. OCT should be viewed as complementary, providing structural quantification, anatomical correlation, and objective documentation. Together, these tools offer a more comprehensive assessment of chiasmal compression.
Dr. Rangachari, usually what is the aim of doing a retrospective study? Why do we plan? What is there in your mind to undertake retrospective study?
So we did this because the quantification of HFA was not compared to OCT in what we did for literature review, sir. So we wanted to see if the HFA defects were correlating with OCT so that we can have an objective.
Does it make any sense in your present day clinical practice when you do such retrospective studies?
I think so that longitudinal study for this would be better to see if the compression, if the progression is affecting the OCT as well as if treatment or intervention is also affecting the OCT.
It's a very vital question. Sir ne kaha na, think about it. Thank
was
you.
it guided by Alzheimer's and RNFL studies? Was it was it because of that you tried to do this?
Sorry.
Alzheimer's and OCT, like dementia, predictive factor of RNFL. Did that guide you? Is it an offshoot of that?
Ma'am is trying to help you.
Protecting you. Protecting you.
The exam.
Next, just a minute. After Vishal, Sneha Batra. Please come over here on the.
You all know your serial number. If you are here, then you join here. You all know serial number.
Yes,
Vishal Rawal.
Good afternoon. I'll be presenting my study titled Microneedle Scleral Patch, a transscleral drug delivery system for retinoblastoma. As we all know, retinoblastoma is the most common intraocular tumor what we see in children less than 5 years of age, and India alone contributes 1500 to 200 cases per year. The most common form of treatment what we do for retinoblastoma is intravenous chemotherapy, and few cases we do try intra-arterial chemotherapy. However, both have their advantages and disadvantages, particularly related to systemic toxicity or technical challenging need of a neurointerventional radiologist and cost for intra-arterial chemotherapy. With that understanding, we wanted to look at a different route for delivering this drug closer to the target area, that is retina, from where the tumor arises. And one such space is the suprachoroidal space, which is potential space between sclera and choroid, and it offers such a promising approach. So we wanted to deliver this chemotherapeutic loaded microneedle scleral patch onto the sclera in a minimally invasive manner. The advantages this patch delivery will have over the current standard form of treatment: it will have a direct and easy access to the choroid and the retinal circulation. It will have a uniform access to all the affected layers and the compartments, but obviously it will be safer and cheaper as compared to the intra-arterial route. So with that, I come to my objectives of my presentation: to design, fabricate, characterize and evaluate the safety and efficacy of chemotherapeutic loaded microneedle scleral patch in a rabbit retinoblastoma model. So in phase 1, we went ahead and designed the master mold using 3D printing technology. The mold was made up of polydimethylsiloxane, into which the polymer what we use for making these microneedles was 4% sodium hyaluronate. Again, it is a natural constituent of artificial tears. We did the characterization of these microneedles using on scanning electron microscope, where you could see how the needles looks under scanning electron microscope. To determine the predetermined depth at which these needles should penetrate into the excised goat sclera, it was found to be around 225 microns, where it reached the suprachoroidal space. We test the compression and the insertion force, so that needle should not break while it penetrates into the scleral surface into the suprachoroidal space. And this is the scan images of the in vitro dissolution of microneedle patch, which kind of needle dissolves close to around 1 minute in 95% constituents. In phase 2, we went with the permeation and biodistribution study in ex vivo, where you could see the applicator is put over to the goat sclera, and you can see after 2 minutes 95% of microneedles completely dissolved. When we look at the amount of topotecan distribution in the ocular tissues, you could see it was highest in the sclera, followed by retina and the choroid. That's where the major tumor arises. And when we compare this with the excised goat sclera in terms of topotecan solution and the patch, the amount of drug distribution with the patch was much higher as compared to topotecan solution. In second part, we went with in vivo biodistribution study in rabbit eye model, where you could see this pre and post application of the patch, and this is close to around 2 minutes after removing the patch. You could see 95% of needles have completely dissolved, and this is intraoperative fundus examination of the rabbit to see there was no clinical toxicity both on the optic nerve as well as the retinal blood vessels. And when we look at the drug distribution at different time points, that is 1 hour, 2 hour, 8 hour, you could see the peak wet end at 1 hour, whereas 95% of the drug went away by 2 hours, and is negligible amount seen at 8 hours. Then we also look at the prototype what we have used to develop this patch applicator, but there was inter-observer variability. To negate that, we again 3D printed a different kind of applicator, which was spring based, where as soon as you remove the plunger, the spring unloads and it gives a uniform distribution of this force onto the microneedle patch to remove the inter-observer variability. Last is about the retinoblastoma tumor induction rabbit model. We are the first one to be developing this in India. So in this, we use 6 New Zealand white rabbits, where we delivered very RB retinoblastoma cell lines in the subretinal space, and out of which 3 rabbits we have used to study the efficacy of this microneedle patch. So these are few of the images where you could see day 0 to day 8. You could see there is a small subretinal tumor which is growing with some kind of vitreous seeding, and by day 28 you could see around the optic nerve a small grayish tumor in the subretinal space, which was confirmed on histopathology that there is a tumor with a small round conspicuous nucleus in the subretinal space, confirming the tumor induction in the rabbit retinoblastoma. With that, we put the microneedle patch again onto the same rabbit at pre and post application of the patch, how the rabbit looks. And you could see at day 19 when they applied the patch, more than 75% of the tumor started regressing the subretinal spares, thereby showing the efficacy of this microneedle patch for retinoblastoma treatment. Again, this was confirmed on histopathology, where you could see there were no seeds in the subretinal spares, but few seeds left in the vitreous compartment. Future work, we have kind of, by this time, we have finished the safety and efficacy of this patch in rabbit retinoblastoma model, and right now we are applying for ICMR grant to go ahead with phase 1 and phase 2 clinical trial for human subjects. This has been patent approved both by ICMR and LV Prasad as a joint collaboration, and I would like to acknowledge my mentor and supervisor at BITS Pinine, Dr. Vamshi Krishna and Dr. Prashant Garg at LV Prasad, and last but not the least, Dr. Arun Singh at Cleveland Clinic, who has the brainchild behind this project, and funding support both from ICMR and LV Prasad Eye Institute. Thank you for your patient listening.
I would have loved this presentation if you had some video assisted presentation, isn't it?
I have a video, but the lack of
No,
time.
that's all right. But you should have know the art of incorporating within a stipulated time. Anyway, what drug you wanted to deliver through this system?
Sorry?
Which drug you wanted to deliver through the system?
Topotecan. This is the standard of care what we give for retinoblastoma. So we have not used any novel drug because then we have to go through the safety and efficacy. This drug has been the first line of treatment for retinoblastoma. That's why we went ahead with topotecan.
This is available as retinal implants also?
No.
Sure?
Yes.
It's direct injections are available.
So that we give as intravitreal.
How do you control the dose of topotecan with this methodology?
So in this patch, this is a 1 centimeter patch which contains 90 microneedles. So in that we use close to around 100 microns on topotecan, which is delivered through this patch. So again, we can play with that depending upon how much drug we want to give in a particular subject or a particular tumor. So that is all variable.
And drug elution studies from that patch you
Yes.
have already done pharmacokinetics.
Yes, we have already done.
Is it similar to, I mean, how will you insert the patch? How far back can you go? Like
So this is like your plaque
Brachytherapy.
brachytherapy. Instead of radiation, we are delivering the chemotherapy.
Wonderful wonderful study done in India. Just for my understanding, you said that you confirmed the diagnosis of retinoblastoma on histopathic examination.
So again,
just a minute.
Induction of retinoblastoma.
Yes, because
Induction of retinoblastoma, and the same rabbit you used for therapy.
No, other rabbit. So there are 6 rabbits where we use for retinoblastoma tumor induction, out of which 3 rabbits we have used for safety and efficacy.
In your talk, you said the same rabbits.
Might be.
Oh, thank you very much.
Thank
So we go to next speaker. Yes, Sneha?
Yes.
Yes, Sneha Batra.
Good afternoon, everyone. Good afternoon, everyone. My name is Sneha Batra, and I'm here to present our paper on efficacy of 5 types of myopia control glasses among Indian children. We do not have any financial interest in any of the products mentioned. So we all keep talking about myopia control, how it is increasing throughout the world, in India, and we need to do something to control its progression. Most of us are already using low-dose atropine. In some places, orthokeratology or RLRL is available. But what is the game changer here is the myopia control glass, because it's a non-invasive thing, a glass which the child is already using. But what question the parents and practitioners always ask, do they really work? What is the proof? And there are so many products available in the market, so which is the best? So our research question was to find out, we've taken 5 different types of myopia control glasses. We wanted to compare their efficacy in controlling the power as well as the axial length progression done at a myopia clinic in North Bengal, India. This was a retrospective collection from 2023 to 25. We've taken progressive myopes only as defined by the myopia guidelines of 2023, and any child who had any other disease or any other myopia control treatment was excluded. Cyclopentolate cycloplegic refraction was done, and the optical biometry was used for axial length measurement. So these were the 5 types of glasses which were compared. Type 1 is DIMS, type 2 is HALT, type 3 is CARE, and type 4 is an older generation peripheral defocus reducing glass, and type 5 was a progressive addition lens. The first 4 types of glasses are based on the hyperopic relative peripheral refraction theory of myopia progression, the last one on the lag of accommodation theory of myopia progression. So what we basically compared was, out of these 5, which had the least change in power and axial length over our study period of 1 year, and the definition of myopia progression, which is given by the myopia guidelines of 2023, that 0.5 diopters increase in 1 year or 0.1 millimeters increase in 1 year is called progression. So we wanted to see how many percentage of children could achieve that. And then we also compared between gender, age group and the baseline amount of myopia. Statistical analysis was done by a statistician using the tests which have been mentioned. A total of 231 children were finally included in the study, and their baseline progression was 1.08 diopters, so they were all quite fast progressors. Now, all of these glasses worked really well because the combined mean refractive error change was brought down to 0.24 diopters, and the axial length change was 0.16 millimeters. But when the statistical test was done, there was a significant difference between the different types of glasses tested. This is the change in the refractive error, and it shows that the type 3 glass worked the best, followed by type 2 and type 1. Type 4 and 5 did not fare that well. In the axial length change, again, the type 3 glass worked the best, followed by type 2 and type 1. When we compare the percentage efficacy, they had a 70% efficacy of refractive efficacy and 46% axial efficacy, again with a significant difference between the different types. Here also, the type 3 glass achieved the best efficacy and followed by type 2 and 1. And in the refractive efficacy, type 2 achieved the best at 6 months and type 3 at 12 months. When we do a pairwise comparison, we see that there is no statistically significant difference between types 1, 2, and 3. But all of them fared much better than type 4 and 5 glass, so we are not recommending them anymore. The box plot also shows that the variation is the least with the type 3 glass, followed by type 2 and 1. There was no main difference between boys and girls, so they worked well for both. Among the different age groups, the lower age group had a lower efficacy. So probably that is because emmetropization is already going on and their rates of myopia progression are much faster as compared to the older age group. Among the myopia groups, we saw that they worked better in the lower myopia groups, but that was statistically significant, but in the high myopia group also they have got good efficacy. So doing a review of literature, we found that there are a number of studies which have shown efficacy of one type of glass only, but there are very, very few literature which have compared any two types of glasses. There is one by Radhakrishnan et al. Which shows that type 1 and 2 are similar, and one by Goa et al. Which showed that type 2 was better than type 1, but comparing 5 different types was not done, and there was no comparative data available from India. So that's the strength of my study. The limitations being that this is a retrospective data collection and non-randomized study. So I'll conclude by saying that in our population, types 1, 2, and 3 were equally efficacious in controlling myopia, and with better results among older children and low myopes. Thank you.
Thank you.
These are my
So,
references.
what was the criteria of inclusion of the children in this criteria? What was the criteria?
Yes. So the age group was 4 to 17 years, and as I said, they have to be progressive myopes.
For how long? 1 year?
Yes. So 0.5 diopters of progression in the last 1 year, which has been defined.
Only 1 year progression, 0.5 you included it?
Yeah.
Not following 2-3 years, increasing 0.5 every year?
No, this is the guideline which has been given by the myopia consensus guidelines of 2023. So which has been published in IJO also, so we followed that.
Okay. Otherwise, actually, it should be having 0.5 progression at least for 2-3 years, because otherwise you cannot say that next year it will increase because of your glasses, or itself it has reduced by number. We cannot say like this.
But each child may have a different rate of progression, so testing one child with one cannot really conclude that this glass is more effective than that. You can't predict the progression.
That is very difficult.
No, but then we have to also understand that the person who's doing the study has to follow some guideline.
Some guideline.
So if there is a myopia control group who are, I believe, more learned, and they have formulated a guideline, we need to give them that credit.
Thank you very much, Doctor.
Thank you.
Next speaker can come here.
Respect. Marian Polly. Respected judges, I am here to share my experiences regarding the outcome of soccer reconstruction involving multiple surgical interventions. In September 2012, 9-year-old child presented to me. He is a known case of bilateral retinoblastoma, right eye status post enucleation with a ball implant at 2 years of age, extruded implant and dermis fat graft done elsewhere. The father came and asked me one question: will my son be able to look normal or near normal ever in his life? This query prompted me to evaluate the outcome of soccer reconstruction in patients requiring multiple surgical interventions, highlighting both the challenges encountered and the strategies employed to optimize functional and aesthetic results. It was a retrospective intervention study from 2012 to 2025 in a tertiary care center in South India. All patients who had undergone 2 or more surgical interventions, excluding the primary surgery, were included, and those with less than 6 months were excluded. Etiology of primary and secondary enophthalmia, type and number of previous socket surgeries, indications for repeat reconstruction, and surgical techniques employed, adjunctive procedures done were analyzed. Patients were followed up at 1 week, 6 weeks, 6 months, and yearly thereafter. The primary outcome measures were socket stability, prosthesis retention, and fornix adequacy. Secondary outcomes were analyzed in terms of graft failure, implant exposure, infection, and persistent volume deficiency. Surgical success was defined as a stable socket that would comfortably retain a prosthesis without the need for any further surgical intervention at final follow-up. Cosmetic outcome was defined in terms of symmetry, appearance, and patient satisfaction, and graded from 1 to 3. We had 15 eyes of 15 patients with age group ranged from 5 months to 58 years. Follow-up ranged from 6 months to 12 years with a mean of 3.1 years. On comparing the primary pathology, 26.7% had intraocular tumors. 40% had enucleation without implant. Surprisingly, 80% of patients presented to us for secondary or tertiary reconstruction. On analyzing the surgical procedures, the most common procedure done was dermis fat graft for volume replacement, followed by debulking and secondary ball implant. Ptosis correction was done in 40% of cases. Total number of surgeries per patient ranged from 2 to 4 with an average of 2.7 interventions. So coming to our first patient, he underwent dermis fat graft debulking in 2018, followed by ptosis correction and lid retraction correction in 2020, and this is his picture at final follow-up of 2024 with reduction in proptosis and improvement in lagophthalmos with a satisfied outcome. So we had surgical success in 100% of cases, and the cosmetic outcome was good in 80% of patients, while 20% had fair outcome due to suboptimal cosmetic results because of residual socket volume and lid asymmetry. No major long-term complications were observed. This is my third patient. She is a 4-year-old child presented to us with, he's a non-case of congenital enophthalmos, status post DFG and canthoplasty done elsewhere. I have done medial canthoplasty and lateral canthoplasty. However, after 11 years, she was remained like this and not very happy. So I did skin graft, mucous membrane graft, canthoplasty, and lid crease formation. This was her final picture. So this is a unique study where patients undergoing 2 or more socket reconstruction surgeries were analyzed. We had retention of customized prosthesis in all patients with a good cosmetic outcome in 80% with no major complications. On comparing the replacement of socket volume, dermis fat graft was the most common procedure done, followed by acrylic ball implant. Choice of implant depends on the condition of the fornices. 33.3% had undergone debulking and all had undergone dermis fat graft till less than 5 years of age. The standard protocol in DFG is to overcorrect. However, in our study, we would like to undercorrect by 10% at least in pediatric age group. However, this needs more volumetric analysis by imaging. Ptosis correction was the most common adjunctive procedure done. Mechanism of ptosis can be multifactorial. The literature is very few. Ariasit et al. Studied 2 to 3 contractures, and up to 1/3 of cases required additional procedures, mirroring our need for multi-stage reconstruction to optimize retention and cosmesis. So this is another child I saw on day 3. This is at 2 years, and this is at 12 years of age with a good cosmesis. Coming to the strength, we did all complex cases with a long follow-up and single surgeon. Limitation, small sample size, retrospective in nature with a mixed pathology. So what this study adds, importance of individualized multi-step surgical planning and problem-based approach. Patients need preoperative counseling regarding the possibility for multiple surgeries. A combination of surface expansion, volume augmentation, and lid correction provides a favorable outcome in restoring function and cosmesis in socket reconstruction. These are my references. Thank you. Thank you. Thank you, sir.
Again, what is the control group for you?
Sir, no control group in this because all complicated cases.
Yeah, all complicated, but alternatively you can do in a long term.
Yeah, thank you, sir.
Control you can always pick up from other centers if there's a similar study.
Yeah. Actually, we are planning to combine.
Dr. Khati, please take the podium as Selja. Can you start?
Yeah, can I have my slides on? So, good afternoon everyone. I shall be presenting the results of my study, which is a cross-sectional genotypic study of Indian patients with microphthalmia, anophthalmia and coloboma. I have no financial disclosures. So microphthalmia, anophthalmia and coloboma, which I will be referring to as a MAC complex of disorders, are complex whole globe abnormalities which are emerging as a leading cause of childhood blindness in India, which are 20% in the population-based study and 55% in the blind school studies. If you look at the etiology of MAC disorders, there can be genetic basis which accounts to around 20 to 30% of the causation, and some environmental factors like maternal infections, drugs and maternal vitamin E deficiency, which account for around 10 to 15%. But largely 50% of them we do not know why does it happen. There is some gene environment interaction between vitamin A and retinoic acid pathway, which also has been suggested. So there are challenges in managing MAC disorders. These have no cure, hence prevention makes a major role. If you want to prevent the environmental factors, you have to improve the maternal health and deficiencies, which is out of purview of most of us. So we can go in for the genetic factors by addressing the consanguinity in the families, genetic counseling of at-risk families, and prenatal and preventive testing. But there are challenges even in the prenatal testing in our population per se, because this disease is sporadic. There can be a lot of genetic heterogeneity in it. There can be non-coding regulatory elements that heavily affect these genes, but more likely because many causative genes likely remain undiscovered, especially in an Indian population, and the yield of next generation sequencing varies between 20 to 50% in most studies. When we look back at the studies which have been done in India, there are only 3 very old studies using old technology, and several candidate genes have not been covered in this. So the aim of this study was to study the genetic profile of MAC patients in India using next generation sequencing, and to know the yield of whole exome sequencing in MAC patients and what proportion are likely pathogenic or pathogenic. This is ultimately improve our understanding of genetic factors involving MAC disorders, thereby improving the clinical genetic counseling and prenatal testing, and also maybe form a panel for our Indian patients. It was a hospital-based study involving 50 patients of all ages. Patients with bilateral MAC, multiple affected family members and or consanguineous parents were included. We excluded simple posterior microphthalmos or nanophthalmos and excluded environmental exposures other than vitamin A deficiency. These are the phenotypic definitions which were used in the study. A severe phenotype of MAC was defined as a child with bilateral anophthalmos or severe microphthalmos or a combination. This is a study methodology. The patients were enrolled, a consent was taken, genetic counseling was performed, deep phenotyping in the form of environmental questionnaire, ocular examination, and systemic examination was done by a physician or a pediatrician wherever applicable. Sample was collected, which was 2 to 5 ml blood. It was stored, and then eventually next generation sequencing, which was whole exome sequencing, was outsourced to a CLIA certified lab, and the study was supported by testing was supported by the Wheeler Stiftung grant. This is the performer that we used, which is a very detailed performer. Coming on to the results, 50 MAC patients of bilateral disease were included. The average age was 9.2 years. The 22 were males. This is the most common type of MAC was coloboma with microcornea, followed by simple coloboma. Severe MAC phenotype was seen in 32%, and a positive family history was seen in 24%. And parental consanguinity was seen in 6%, and systemic findings were again seen in 32%. Now coming to the results of the whole exome sequencing, we got genetic variants in 19 of these patients, which gave us the yield of 38%, out of which autosomal dominant were around 36% and autosomal recessive around 42%. Among those who had a positive mutation, then the point mutations were seen in 79%, and copy number variations, which are deletions, duplications, were seen in 21%. Among the point mutations, 80% of them were missense mutations. As expected, lightly pathogenic and pathogenic variants were just seen in 4 patients, which is 21%. Rest all were variants of unknown significance, signifying that these could be potential new genes or new variants. When we compared the patients who had positive test versus those who had negative test, among these parameters, which is a severe MAC disease, a positive family history, parental consanguinity or systemic findings, only parental consanguinity came to be positive. These are the candidate genes which were seen. Now the bold ones are those which are likely pathogenic or pathogenic. The underlined ones are those who had a severe MAC phenotype, and the blue ones which are not usually associated with MAC but were found positive in these patients. And there were 3 genes, which is the MAB21L2, the aldehyde dehydrogenase, and the frizzled, which were seen in our population. This is a comparison of the other tests, other population where it is found to be. This is strength of a study, first genetic study used in WS, and limitation is little small small sample size. To conclude, MAC is a genetic heterogenic disease in a population. The yield of WAS is 38%. It was better in parental consanguinity, and 79% were variants of unknown significance, which needs more work. So Thank you.
What is your message for a general ophthalmologist for in his clinical practice?
So basically these disorders are currently with no cure. So what we need to do is like to prevent. So often it is understood that we can do genetic counseling and advise them to have a next baby which does not have disease. But when we do this whole exome sequencing test, we'll end up in getting variants of unknown significance. Those are not pathogenic because we have not studied our own population. These tests are against population data which is from other population other than Indian population. So this is a way to improve the yield of our own population tests so that in future we can give them more structured genetic counseling.
Thank you.
Thank you.
So,
no, this is a hospital-based study.
Yes. Dr. Saveline Kaur here. Yeah, you can come here. So Dr. Jain, you can.
Good afternoon, everyone. So moving on to refractive surgery. So this paper is on a new simulation-based software that I developed for doing presbyopic LASIK in hypermetropia. The basis of my software is based on a mathematical model proposed by Professor Gattinel in 2016, which talks about Q-value modulation to increase the depth of focus. What he proposed was you make the non-dominant eye very highly hyperprolate by changing the Q-value by 0.6. So if the starting was -0.2, you make it -0.8, and then you have to add refraction onto it so that the depth of focus comes. In terms of optics, this is how it works. If you have a hyperopic cornea, where the rays are focused behind the retina, you do a hyperopic treatment by ablating at the periphery so the rays focus on the cornea. But if you give extra ablation only in the periphery and not do it in the center, that causes a non-linear profile, and this increases the Q value. It makes it more negative, so that the rays now from the periphery are focusing behind the retina, but the central rays focus on the retina. Then when you add refraction, all these rays come on the retina and you get a depth of focus. So this was the mathematical model. But what I realized with experience is that making a Q value modulation of 0.6 significantly affects the contrast sensitivity. So what I found was that up to a 0.36 change in Q value, the quality of vision is not affected. So I came up with a controlled asphericity modulation for presbyopia, where we go up to a maximum of only 0.36, and in this way we can treat both the eyes. And by treating both the eyes, we can use the patient's natural accommodation as well as the patient's monovision, and all this can be seen on a simulator which I developed called the Zoom simulator, which I'll show with the help of an example. This is the refraction of the patient, distance and near. We define something called as binocular inherent accommodation, which is the accommodative effort the patient still has, which is 2.5 minus the reading add. And then we also do a monovision test to see how much is the maximum tolerable monovision. And then we open the simulator. The simulator basically shows you ray diagrams, and based on these ray diagrams, you can feed in all the data. Once you feed in the data, it will show you on the ray diagram how much of depth of focus is being induced. And then you have these bars to change the Q value. And once you change the Q value, you get the maximum depth of focus you can do for the distant dominant eye and near dominant eye. And using these guidelines, we can actually then modify the refraction. So the software tells you what is the final refraction to put in the right and left eye, and the final Q value you have to change. So we wanted to study the safety, efficacy, predictability, patient satisfaction at 6 months post-op. We retrospectively analyzed all hyperopic presbyopes between 40 to 60 years and excluded any complicated cases. And we got 26 patients with 52 eyes in this study. The surgery was a standard femto LASIK that was done for all the patients, standard protocol. All post-operative assessment was done at 6 months post-operatively, including the uncorrected distance and near manifest refraction corrected distance, and we also had subjective questionnaires. So these are the results where we can see the age group, mean age group was 48 years, and the mean refraction was around 2 diopter spherical equivalent with a 1.7 cylinder. Now this graph shows the uncorrected distance visual acuity. If you focus on the green bars show you the number of patients who had binocular specific vision. So 6x6, there were 88% patients who crossed 6x6 binocularly. And the yellow bars are interesting because the yellow bars are the near eyes. And the near eyes also, it shows you 81% patients were 6/9 or better for distance. So that is the effect of depth of focus. Similarly, this is the unaided near vision that we can see. The green bars show you binocularly where 100% were J3 or better, and the blue bars show you the distance eyes. So the distance eyes also, 92% of them were J5 or better for near. So the idea of increasing the depth of focus in a controlled way is that the distant dominant eyes also can see good near, and the near dominant can also see good distant. And because of that, we are getting a good binocular depth of focus for these patients. The safety profiles were met, which was defined by Journal of Refractive Surgery, where more than 2 lines of loss of vision should not be there, so there was 0% eyes. And these are box and whisker plots to just show how we have targeted the distance and near eyes, and they have come close to the target. Subjective questionnaire for distance satisfaction, near satisfaction, unaided reading comfort was on a Likert scale from 0 to 10. All these values were around 8.5. 77% patients said that they had spectacle independence, whereas 23% said they were partially spectacally independent. And dysphotopsia score, 88% patients said that they had zero dysphotopsia, whereas 12% patients said that they had mild dysphotopsia. So the CAM protocol with the Zoom simulator offers safe, effective, and a customizable approach for treating hyperopic presbyopia. Currently, it's only been tested on the Wavelight platform. Thank you.
I'll just give a question. One question?
Yeah, one question.
So you said that you arrived at a figure of minus 0.36 as a Q-value, which was the tipping point.
Yes, sir.
Where did you arrive? How did you arrive at that? Your own study or some other study?
Yes, sir. It was own pilot data from which...
what sample size?
Sir, it was done over a period of 1 year. There was a lot of trial and error done where we found that when you go to 0.36, the patients are able to get a decent depth of focus without losing any contrast. But there's no.
Yeah, I'm concerned because when you bring it, incorporate it into a software, it's a good study. It's a very good study, and you brought us. But when you quote this figure, this is going to be questioned.
Yes, sir.
Because that is your benchmark.
So, sir, the thing is that the literature says that you can go up to 0.6.
I understood that. So when you are going something against the stream,
but
against what is published,
we are not going beyond.
So anyway, and second thing, what was the stability over a period of time? You said studied it for 6 months.
Yeah, this data was checked at 6 months.
Presbyopia correction is the biggest bugbear is that over a period of time it wears off.
Right, sir. And the patients were counseled that they may require touch-ups later. That is something that we have to.
Thank you. Good study.
Thank you very much. Dr. Savlin.
Dr. Chauhan, sir.
John, please take a position, and Savlin, you please start.
A very good afternoon, everyone. Can I have my slides on, please? Yesterday night, I was looking at the past recipients of the Colonel Rangachari Award, and I'm not trying to be competitive here, but when I was just trying to look at the recipients, all I'm trying to say is that I was looking for a strabismologist who has won this award. Not because, again, I'm trying to be competitive. Of course, I found Dr. Pradeep Sharma sir there. But as a speciality, we are only a handful of dedicated strabismologists in the country, and residents by and large do not want to take this speciality. That is the background of my studies. Even basic strabismus surgeries are done at tertiary care centers, pretty much because all our methods are based on reflex tests and cover tests and prisms, which are mathematical, and we do add a lot by clinical knowledge and observation, but these tests are all rendered to an inter-observer variability, making our measurements very, very subjective, and I think that is why we do not like to pursue it, perhaps. So we wanted to devise an automated, scalable, repeatable methodology which could tell us what is the classification of strabismus and then probably measure it. So we used artificial intelligence to integrate into a camera-based device for the quantitative diagnosis of strabismus, which can be used for a general ophthalmologist also. The study was divided into 3 phases. The first phase being that of a model development. We were lucky that we were able to build a platform based on deep learning method. It is applied for a patent, and we tested it on a small subset of patients. The second part of the study involved validation of this model on a larger subset of patients where we are doing surgery and we could measure it against the prism diopter values, and then probably go on to development of a device which can tell us what is the diagnosis of squint and then quantify it for us. I'm going to be discussing the validations phase of the study as compared to the prism diopter values which we measure before surgery, measured by a strabismologist. We recruited patients aged 4 years and above at the Advanced Eye Center PGI. For the present study, we used only comitant strabismus, all those patients who had an ambiguous diagnosis of squint, all those patients who had a phoria, and those having comorbidities were excluded for this part of the study. The photographs were taken on a 12 megapixel smartphone camera with the same photographer at a distance of 35 centimeter. The images were all processed, standardized as far as the magnification and illumination was concerned, and then fed into a YOLO-based model. It is a convoluted neural network that is freely available. The facial input image goes something like this. The eye segmentation is done by the software, and the software is taught to identify the lateral canthus, the medial canthus, and the pupillary center. At present, this model is actually looking at the reflex displacement. So it is based on the reflex test on one single photograph and is trying to measure and give us an index of the deviation horizontally as well as vertically. So the principle is pupillary displacement and to some extent angular deviation. We did all statistics on the Excel with a p-value of 0.05. We have now recruited about 500 patients who are undergoing squint surgery and matched them with an age match, gender match, and refractive error matched controls of 300 patients. Most of the strabismus that we saw was horizontal, and so we had a predominant exotropia in our study group. When we give the software the images, it classifies it into normal and abnormal with an accuracy of 94%. And when the model thinks that you have strabismus, it will tell you whether it's ESO, exo, hyper, and hypo to the accuracy of about 90%. This is how the software works, and we tried, this is a box whisker plot telling us the various subtypes of strabismus. We had more horizontal, and we also found that this correlation that we observed for the horizontal deviation was very high as compared to the prism diopter values. We did observe a weak correlation, but at present very less for the vertical deviation. To conclude, it's a deep learning system that is combining real-time classification with quantitative strabismus evaluation. It can be a relevant tool for ophthalmologists not practicing strabismus as well as in the teleophthalmology setting. At present, it works best for horizontal strabismus. We are just setting the stage. We have a long way to go because we have not validated it in a subset which is beyond North India. We have to test different age groups, different ethnicities. We have not yet recruited complex strabismus. We have yet not included latent strabismus, and we are into the hardware building. We are collaborating with the Department of Electronics at Thapar Institute for that, thanks to my mentor and my faculty at Advanced Eye Center.
Everything sounds very nice when you talk about any new software in any, of the techniques and all that. Did you try this software in cyclotropias also?
So we actually included some patients who had both horizontal and vertical deviation, including some cyclotropias like a case of superior oblique palsy. It gives you an index right now, but it's not very accurate when you have a cyclotropia. So we have to test more and more patients to make it
That's
more
what
accurate.
I was trying to point out, that you have to take care of cyclotropias because we do get cases of cyclotropia in our clinical practice.
I agree, sir.
And many of us fail to have a proper assessment of cyclotropias.
Yes.
What to talk about the management?
So we have to just begin. So we started with horizontal and we are moving on to more complex.
At least ophthalmologists were doing cover tests. Now we stopped that also.
Thank you.
Basic things should
do anything if this
Thank
works.
you. Thank you.
Thank you.
Dr. Yogita Gupta is there because she was not there when her turn came.
She has not come.
So I think
Professor Rajendra Singh Chauhan, sir.
This is the last chance for her. If anyone, any friend is there, call her.
Call her.
Otherwise, we will strike it
Only
off.
being generous.
Rima Bansal.
Yeah.
Professor
Dr.
Rima Bansal here.
Bansal, yeah.
I can see.
You can come to
Please come on
this podium.
Rajendra, you can start.
And Dr. Rajendra sir, you can start.
Good afternoon, respected chairperson and my dear friends. These are some unconventional and rare traumatic situations where you need to think out of the box and to establish a diagnosis and treat accordingly. This is the first case, which is a flying fish injury. It was in 2007 in the Gulf of Oman when a small child of 12 years of age was swimming in the sea. He was hit by some object and he developed orbital cellulitis. He was treated at the peripheral health center with antibiotics, but even after 10 days he was not relieved. So he was referred to us, and the X-ray didn't show anything, but then the CT scan was done. The Hounsfield unit of there was a linear intraorbital foreign body, which was the Hounsfield unit of which was more than bone and less than the metal. So it was suspected some intraorbital foreign body, and we had to go into the depth and in the details. And the father actually told that probably it might have been hit by a fish which is called garfish or the flying fish, which is also called needlefish in the sea. So he brought the fish, and that fish was seen, and the big beak was broken, and that was also CT scan was done, and it was correlated with that intraocular found body, and that was removed. This paper was presented later on. This is another case where avulsion of LASIK flap. He was a 25-year-old kabaddi player who had injury while playing kabaddi, and this LASIK flap was avulsed, and when it was cleaned and washed in the theater, the cornea became white. But next day there was some debris, and later on the patient developed sand of Sahara. But over a period of 1.5 months with the topical steroid and antibiotics, he was relieved. So this was the end result of that case. And then the third case was this was a young female, 18-year-old female who had pencil injury, and which was lying there for the last 18 years. So it was removed because it didn't cause any problem except for the astigmatism. So it was inert, and when it was removed, there was a leakage, and this leakage was treated and sutured, and ultimately the patient was well. So this is another case. This is a very interesting case. This was an IPS officer. He was Director General of Police Services, and he didn't allow anybody to touch his eyes, and he was having non-healing corneal ulcer. But I counseled him, and then I told him that I need to touch your eyes, and then only I would be able to treat you. Then he allowed me, and then when I everted his upper eyelid, to my utter surprise, under the upper eyelid he was having a ring of cap of the eye drop. So that was treated later on. Thank you.
I think Dr. Chauhan has highlighted some of the very commonly seen cases in our clinical practice, and these cases do not require any software, mind you. They require your own clinical sense to cope up. Thank you.
Thank you. But we should continue with, we should move forward, so we have to need to the application also. So Dr. Nina, you can start now. And the last speaker is
Simran Rajan. Simran Rajan.
Please be ready, and yes. Thank you, sir. A very good afternoon. Complement system is a key part of innate immunity involved in inflammation. Its dysregulation has been reported in diseases like AMD, diabetic retinopathy, and various uveitis. There is no published data of complement mutations in serpiginous like choroiditis due to TB. These are some of the eye diseases that have been associated with complement factor mutations. The environmental factors like TB and genetic susceptibility produce local RPE choroid inflammation, which is aggravated by complement activation and inflammatory mediators, leading to development of serpiginous like choroiditis. So with this hypothesis model and the fact that TB SLC involves significantly the RPE, which in turn express complement proteins, we conducted this study with the aim of assessing the possible association of complement system gene variations with TB SLC as the first objective, with the candidate genes as listed, and to assess any correlation of the genotype with the disease spectrum as the second objective. To maintain a case control ratio of 1:4 for genetic studies, we enrolled 30 patients in group A with TB SLC, 30 patients in group B with TB uveitis other than SLC, and 90 healthy controls in group C. A custom amplicon-based NGS was employed on peripheral blood DNA samples of these subjects, single nucleotide variants, the SNVs, insertion deletions of the indels, and copy number variations and the CNVs were annotated and mapped. The human genome is primarily 99.8% identical, and it is only by 0.2% that we differ from each other. Out of these, 90% variations are contributed by SNVs and 10% by CNVs. Coming to the results, both group A and B had 43.3 variations as compared to group C, which had minor variations, 4.4%. This shows the clustering of pathogenic CNVs in group A, clustering of pathogenic SNVs in group B. Coming to the complement class of proteins, group A was dominated by proteins while group B had both equal proteins and regulators. The alternate pathway was predominantly expressed than the classical pathway in both groups A and B. This shows the copy number variations identified by NGS in patient number A2 showing a homozygous deletion and patient number A4 showing a large copy number gain. Coming to the second part of our results, Sanger sequencing, these are the genetic variants gene C5 and C3 detected by NGS in patient number A1 and A5, validated by Sanger sequencing showing 2 heterozygous peaks corresponding to G and T in first patient and T and C in the other. Group B, the genetic variants identified in gene C3 and CFB in patient number 2 and 3, validated by Sanger sequencing showing heterozygous peaks corresponding to A and G. The third part of the results was clinical spectrum and genotype correlation. We had 21 males and 9 females in group A with mean age of 33 years. The adverse events like paradoxical worsening and recurrence were seen in 38.5% in patients with variations as compared to 23.5% in those with no variations. We did not find any genotypic correlation with bilaterality, gender, type of SLC lesions, adverse events, or chest CT findings. However, the odds ratio of adverse events was 2.9, suggesting its tendency for association with presence of complement factor variations. Coming to the SWOT analysis, the strengths of our study, it's the first study of its own kind. It's a prospective case-controlled study where we analyzed both SNVs and CNVs and validation by Sanger sequencing. We do have some weaknesses. It's a targeted NGS and not a whole exome study. We have limited cases and vitreous fluid complement was not studied. It provides opportunities to design a prospective validation analysis study, to perform functional analysis by in vitro studies, and to explore anti-complement therapy. Some threats genes detected are mostly heterozygous and difficult to create a model with interplay of multiple complement proteins. So to conclude, our study suggests the role of complement factors in tubercular serpiginous choroiditis with genetic and pathophysiologic overlap between the two TB uveitis groups. The genetic mutation possibly influences the TB phenotype, that is the CNVs favoring SLC and SNVs favoring non-SLC TB uveitis, and we are now currently working on prospective GWAS to address these phenotypic differences. The implications of our study for tubercular serpiginous choroiditis, it does address certain gaps in pathophysiology, but more importantly, it opens new avenues to explore complement factors as potential therapeutic targets. I would like to acknowledge my co-investigators and thank the Government of India for providing funding to conduct this study in our institute. Thank you very much.
Thank you, Dr. Nima. How you have confirmed the diagnosis of tubercular choroiditis?
So this was followed as the classification given by the classification of intraocular tuberculosis. So the TB SLC patients are diagnosed in our clinic based on the phenotype. Number one, the presence of any immunological test positive or radiological test positive, and we start them on anti-TB therapy.
Thank you.
Thank you, sir.
We can start with the last talk. Dr. Simarajan Singh.
Thank you, sir, and thanks to the AIOC Scientific Committee and the judges for this opportunity. I'll be discussing about a diagnosis that we have been increasingly recognizing in the recent years, that is persistent avascular retina in retinopathy of prematurity and the ultra-wide field imaging features consistent with the same. Persistent avascular retina has been defined as incomplete vascularization in the retinal periphery after spontaneous or anti-VEGF induced regression of ROP. More than 2 disc diameters of avascular retina is considered significant and labeled as PAR. In the literature that is present, we have seen that PAR can be present even without developing ROP, but in a very less number of patients, 3.2%. But with spontaneously regressed, as well as now with the increasing use of anti-VEGF, the anti-VEGF regressed ROP can have a very high incidence of PAR, which has been labeled up to even 50% in some of these studies. And in aggressive ROP, this can be very posterior in zone 1, which is an increasing concern, as many of these babies are left without laser after the treatment of retinopathy of prematurity. This is a study from Western literature which shows their incidence of having these abnormalities in these children, and they found retinal detachment in almost 40% of their cases, with 82% of those cases having a significant amount of PAR, which led to the retinal detachment. So ours was a retrospective single-center cross-sectional study conducted over 2 years. Inclusion criteria was clinically detected more than 2 disc diameters of PAR, the child who was cooperative for imaging, history of prematurity with gestational age less than 40 weeks, not under active follow-up of ROP, negative family screening and negative genetics for FEVR-related genes, and they were excluded if they had stage 5 ROP or were uncooperative for ultra-wide field imaging. So this was the kind of presentation that we had. We had 58 eyes of 31 patients. What was striking was 41.9% of these patients whom we picked up, they were just detected in low vision in a routine school screening, and they were sent for spectacles. Somebody saw something abnormal in the fundus and sent to us. 22.5% was picked up prior to refractive surgery when we checked the fundus of these patients. So almost a fifth of them. And almost 40% had been screened for ROP at birth, and 13% had received anti-VEGF injections without any subsequent treatment with laser for the same. The fundus finding shows lattice with atrophic holes in almost 50%, and most of these lattices were in the avascular area. Ridge-like proliferation in about 40% and retinal detachment in about 15% of these cases. Angiography showed us more than 6 clock hours of persistent avascular retina in almost 50%, and neovascularization, which was undetected at this point in almost a fourth of these patients. I'll just show some examples to amplify these findings. You can see this child who was a 9-year-old referred just for low vision detected at school. If you see the posterior pole, it's fine, but once you go to the periphery, if you look at the periphery carefully, you see the vessels stopping short and circumferential lattice with holes that are present. And the angiography tells you the extent of the avascularity that is actually there, even with the 6/6 vision that the child has. Now I of course treat all of them with laser, but we'll come to that later. This one came for refractive surgery, 18 years old patient, 6'9" with -13 and -9. And when you look at the retina, you can see the vessels stopping short, the tortuosity. There was presence of hemorrhage in the left eye, which was undetected, an old hemorrhage, and a lot of vitreous membranes. When you look at the angiography, you again see the significant amount of avascularity that is present and that characteristic tortuous architecture of the vessels and dragging of the nasal vessels. Again managed with laser. Another patient with right eye drag, low vision, left eye you can see that ridge-like proliferation with good vision in this eye, but as soon as you see the angiography, the vessels stop right at that ridge. Another patient presented with low vision in the left eye, you can see retinal detachment with neovascularization in the left eye, but look at the right eye, look at the circumferential layers of lattices that are present, and if you look at the angiography, the vessels are stopping just in zone 2 posterior. Again managed with laser and buccal. Another patient with retinal detachment, managed with buccal, and the angiography post-operatively shows that. And these are 3 patients who all 3 injected with anti-VEGF. Look at the vasculature, so much of neovascularization, and they are just left as it is. And this one is especially important. A patient with -16 diopter came for ICL. Left eye prophylactic laser has been done to the hole, but right eye nothing has been done. Look at the avascularity in the right eye. So much of avascular retina that is still there, managed with laser and buckling in the left eye to give that patient vision. So to conclude, with the increasing incidence of premature births, there is need to identify this entity known as persistent avascular retina. Avascular retina is prone for development of lattice and breaks that can lead to retinal detachment, and timely treatment of these can help prevent these complications. Thank you.
Yeah, how do you rule out FEVR in this subset of patients?
So that is what we particularly did, sir. The purpose of this study was actually this, that we need to differentiate these features from FEVR. So we have those typical supranumerary vessels coming out of the disc, which is not true in this. We have some tortuosity and the changes in the periphery. But what we did from our side was, one, we examined the parents as well as siblings. For FEVR, at least one parent you would have, since it's mostly autosomal dominant inherited. And along with, we did whole exome sequencing for the Wnt pathway genes, which had to be negative if we included it in this study.
One recommendation that you'd give to the ophthalmologists at large from your study?
Prior to refractive surgery, all myopes look at the periphery very carefully, yes. And especially look at the vasculature, not just the lattices and that, but look at the vasculature where it is stopping.
Screen for prematurity.
That is something I have started doing.
Otherwise also it's a standard recommendation. Any myopia fundus you see, you must screen the peripheral part of the retina more carefully.
Absolutely. We look at the vasculature also, sir. The changes are mostly vascular rather than the lattices that we normally see.
Thank you.
Thank you very much. Thank you everyone.
Thank you everyone, and good wishes to everyone.
All the
Best
presentations are of very high standard.
Yeah.
We think very neutral and we scored. The tabulation will be done by the scientific committee. They will announce the results tomorrow. Not now.
Today.
Difficult job. Difficult job.
Good luck to everyone.
ये पूरा भाई सील करके भेज देना।
ये फोटो तो हाथ हो जाए।
हम तो
सर ऐसे ही है। ऐसे ही सर फोटो खिंचवाना और है।
क्या हो गया?
मैडम आओ थोड़ा बैलेंस करो।